Welcome to our fifth webinar on Spice Route GP's Café, Sri Lanka. Today, the webinar will be moderated by Dr. Praneeth Nishad. I'm Dr. Asita, Spice Route Chair. So, Praneeth Nishad is our eminent doctor who is our CPD coordinator, and he holds DCH and MCGP diploma. So, Praneeth is a medical officer of health at Horana MOH. I invite Praneeth to introduce the presenter and start the webinar. Over to you, Praneeth.
Thank you, Dr. Asita, the national chair of our Spice Route. We are now heading for the fifth session of our GP Cafe. Our presenter will be Dr. Supipi de Silva. Her qualifications and information I will share now. She's a Sri Jayawardenepura University graduate who had her MBBS degree, and she's a trainee in MCGP 9th batch, and she's a member of our Spice Route team as well. She's an active member and practicing as a GP for more than 15 years now. Now her practice is at Katunayaka, and her medical center is St. Anthony's Medical Centers is now for 3 years, and she's now working as MOH for the Katunayaka BOI zone as well, and she is interested on rheumatoid as well. I will hand over Supipi for the presentation. If there's any technical matter, I will help her. I will ask now and invite her to present her for the fifth session. Thank you.
Thank you very much for your kind words, Dr. Praneeth. Good evening, everybody. I welcome all of you. Can you hear me?
Yes, we can hear you, but the slides are not on the slideshow. Please make it.
Thank you very much, Dr. Praneeth, for your kind words. Good evening, everybody. Can you hear me? Yeah.
Yes, go ahead.
Good evening, everybody. I welcome you all for today's session. First of all, I have to give my heartfelt gratitude to College of General Practitioners in Sri Lanka for giving this golden opportunity for me. And first of all, before that, starting my presentations, I would like to tell something about the general practitioners. General practitioner is the person who gives the first contact care for the patient. So he might be having a vast knowledge, attitude, and experience and skills of not only the main subjects such as medicine, surgery, but also but also on the subspecialties such as rheumatology and dermatology. And he's having a good attitude, and he is giving the holistic approach for the patient-centered care, and it's give from the womb to tomb, and it's contain the comprehensive care, continuity of care, and preventive care, and the family care also. This is the patient. Today I'm going to describe. I encountered this patient 3 months back in my private practice. Before starting my presentations, can you see my slides to all? Can you see the slide?
Yes, Dr. Supipi, yes.
Yeah.
First one,
Somebody can explain what is the meaning of these slides. Being a human being, we are starting to walk. Then can somebody try what's our meaning?
Rosen.
I suppose it's the steps of development.
Yeah,
Yeah.
exactly. In first day, we are starting to walk. What happened when you are starting to walk? We will fall down, but we are not stop at that time. We are trying to get up from walking, from this falling, and we try to walk. That is the success of our being a human being. That also same as that we can apply to our general practice also. When we encounter any patient, any event, after analyzing, sometimes we may having some reflection. With the experience of these reflections, we can take a good future activities, isn't it? Today, my topic is reflection is a better start. This is the patient that I encountered. Mr. UF, 35 years old patients complain of left-sided chest pain for 1 day duration. What are the things you would like to gather from the history?
type of pain and associated with like sweat pain, radiation of pain.
Yeah. What are the other things you would like to ask from the patient?
We have to exclude a cardiac case as well as other causes for chest pain.
Yeah, very good. This patient is a 35-year patient who is working at a free trade zone. While he is doing the work, he have to lift heavy works. The history that it was a throbbing left-sided chest pain and remained throughout the day. There's no radiation to arms, shoulders, or jaws or any places. It's not precipitated by exercises or movements or breathing or cough. And it was not relieved by the rest, and it's not he has taken while he's on duty. he has taken 1 gram of paracetamol from the nurse at the sick room, but it was not responded. And he is not having a recent trauma, not associated with shortness of breathing or faintishness of palpitations, not associated fever, nausea, vomiting, or regurgitation. Then what would be the differential diagnosis for this case? In past medical history also, he is a diagnosed diabetic and hypertension for 5 years duration, but I followed him for 8 months durations, and his drug compliance also satisfactory. Last HbA1c I did in 3 months before this attack, that was 6.8, and his blood pressure throughout is normal, around 130/80 like that. And he's not having any history of allergies to drugs or fruit. There is a family history of ischemic heart disease with his father, and according to him, the father had a minor stroke, I think, and no significant history of ischemic heart disease related deaths. And his mother also a diabetic patient on regular treatment. In social history, he's a father of 2 children, age of 10 and 12 years, and he's a manual worker. Before I explained, his wife is a housewife, and they were at the rented house. Then there's no having the extended family support for them. He's smoking around 2 to 3 cigars per day. What would be the differential diagnosis for this patient? Any guesses of differential diagnosis?
Muscular
Mind-
pain.
Sorry?
Ischemic heart disease.
Yes, we have to exclude ischemic heart disease because he's on diabetic and hypertensive treatment, and there's a family history of first degree of family history with ischemic heart disease also. Very good.
Muscular pain.
Yes, muscular pain. Why you thought on muscular pain? Because he's a heavy manual work also. Right. My differential diagnosis came as that ischemic heart disease, costochondritis and other musculoskeletal disorders, gastroesophageal reflux disease, pneumothorax and pneumonia. After that, in examination, what would you like to know?
Any tenderness over the anterior chest wall and blood pressure and the pulse rate and other things.
Yes. In examination, the general examination, he is in pain, not pale, not in shortness of breathing. Cardiovascular system, pulse rate was 84. It was regular, normal volume. Blood pressure was 130/70, and heart sounds were normal. In respiratory system, respiratory rate around 15 per minute, and equal air entry, and there's no added sounds. And left-sided, when I'm pressing left-sided, local tenderness also there. So what would be the differential diagnosis? after examination findings. Do you want to have another examination findings?
It's more in costochondritis.
Yeah. In my differential diagnosis, I took as musculoskeletal disorders and costochondritis, then ischemic heart disease and gastroesophageal reflux disease and pneumothorax. Then investigation, I ordered ECG, urgent ECG, because I want to exclude any cardiac event because he is having a diagnosed diabetic and hypertensive treatment, and he's having a family history of ischemic heart disease and diabetic also, and he's having the risk factors of smoking also. Then I request urgent ECG. Then I did the random blood sugar. That was 142, and chest X-ray and full blood count and ESR also was in my mind. The ECG, it was sinus rhythm, no ischemic changes. Other investigations I didn't do. With my experience, I did watchful waiting for that. Then I did the management as that. I reassured the patient. Then opportunistic advices given because of the smoking, and he was willing to stop that time. Then I have given a paracetamol 1 gram TDS and celecoxib 200 milligram BD and omeprazole, and asked to continue the routine medication, same as I reassure him, if you're having a continuous pain, you have to review it again. Then what's happened next? 2 days later, he complained of severe chest pain, and he told he not had sleep for last 2 days. Actually, he told doctor, මට නිදා ගන්න මොකක් හරි දෙන්න. He told me. Then my eyes opened. Then what was the diagnosis? Is it a wrong diagnosis? Or what shall I do now? Like that, I was worried that I didn't repeat the ECG because he is having a risk factors and diagnosed hypertensive and diabetic, and is the interpretation of my ECG was incorrect. Then I thought whether to repeat the ECG or chest X-ray. Then I differentiate my diagnosis first as a acute coronary syndrome or pneumonia or pneumothorax. Then I thought to do the proper history taking, examination and investigations again. What would you think about the diagnosis? Any thoughts?
Post-herpetic neuralgia.
Sorry?
Post-herpetic neuralgia.
Yeah. Yeah. That time, very first day when he came after finishing his work. He had shirts and everything was in full kit. This day he came with a t-shirt because he is in pain, severe pain. While I am examination, that was the picture. I had. What is this?
Yes.
Varicella zoster.
Yeah,
Shingles.
yeah. Varicella zoster that I missed. Then I change my treatments again, non-pharmacological treatment, the nutrition and good hygiene, hydration and isolation, and continue the drug treatment for diabetic and hypertensive. Also very important. I advise him about all the factors he have to do. And pharmacologically, I started acyclovir 100 milligram 5 times daily for 7 days. And I have given paracetamol and celecoxib with omeprazole. Because of the neuralgic pain, I started gabapentin 200 milligram noctane. Then I asked about the family members. What do you think with the vaccination needed? Fortunately, in my patient, they all get chickenpox around 10 years back. Prophylaxis acyclovir is important or vaccination, how it's effective. And same times, I inform the MOH also. In family medicine, I think I have done the comprehensive care, continuation of care, and preventive care, coordination of care while handling this patient. My reflection is need to have a full examinations of the relevant system, because first time, at the very first day, when he's coming, I didn't expose him well. I didn't remove his clothes. And I didn't analyze, I think, his complaint well. The chest, I thought on chest pain that might be most common things are common, but I have to think about the rare cases also. If I analyze the pain, if it is a neurological pain, I would not able to do this reflection, I think. Shingles. Shall we discuss about the shingles? Shingles is having because of the after chickenpox. The virus remain in the posterior ganglions of the neurons, and reactivation after immune suppressive condition. Then it's called zosters. Normally, it's occur 10 to 20% of the patients, and it remained 2 to 6 weeks, and the incubation period is 2 to 3 weeks. You can see the chickenpox, then the virus is staying in the peripheral nerve and the ganglion, that again reactivations occur. Through the direct contact with the source of the shingles, it can be infected to others, but less chance. After crust formation, there's no infective status. The risk factors for that is age more than 50 and chronic diseases as HIV, AIDS, or cancers such as leukemias and lymphomas. Sometimes some patients on immune suppressive treatment, chemotherapy, radiotherapy like that, and some medications. In long-term steroid therapy, but it's not affect the inhalation of steroid we are using for the asthma patients. The complications are post-herpetic neuralgia because it's damaged the nerve fibers. And it can, I think in our medical schools, you can remember the trigeminal nerves, it has 3 branches. If it is affected the ophthalmic branch, it causes ophthalmic shingles. That can cause optic neuritis, vision loss also, blindness. And encephalitis, facial nerve palsy in Ramsey-Hunt syndrome. And it will cause hearing problems. And if the skin infections by the bacteria also, that can be taken as a complication. Treatment, zoster vaccination, but it's not recommended. Treatment for acyclovir, famiclor, we can use, but it is debatable. It's still, if you are immunocompromised, it's have a generalized shingles, then you can use. And if you are having the ophthalmic shingles, we can use. Otherwise, we don't give the treatment, prophylactic treatment. And for the pain, we can give the anticonvulsives such as gabapentin and antidepressive amitriptyline like that, and lignocaine also. I would like to speak the primary infection, that is chickenpox. I think you have heard. That is also a varicella zoster virus infection. That is not a life-threatening other than the adults, old age, and immunosuppressions or neonates. Clinical features are fever, generalized body pain, and rash. If it is clustered, it's not infective. It started mostly in the face and the head and the exposed areas. The worst thing is if it is in a pregnant woman or low immune status or neonates, that can be having some complications. The complications are also same as that, pneumonia, skin sepsis, encephalitis. And if you are having a congenital varices, you will get the prematurity and the congenital varices syndrome also. The mode of transmission is person to person can direct contact. And most of chickenpox, most of the time, the virus is in the nasal pharynx. So when you are sneezing, coughing, that can be infected to the others. Very sorry, I mean that Kadunayaka, so plates are like vesical fluids of the patients with the herpes zoster also one cause of infection. The infections occur 2 days prior to the rash come. So we don't know if the patient is having a rash, we can diagnose it as a chickenpox. But before 2 days back also, the person is infective. And more 10 to 7 days also after rash. But if it is clustered, the infective rate is very low. And after chickenpox, we get the lifelong immunity also. In newborn babies, they also get the immunity from the mother for few months after birth. We don't need to treat all the patients for chickenpox, but we are treating most of the time. Treatment is, we can give drugs, acyclovir, and medical advising. Most of the time, we, as a general practitioner, we have to ask to trim the nails, and aspirin and other things we have to avoid, that will lead to race syndromes. And vaccination in chickenpox, there are 2 types of vaccination, pre-exposure and post-exposure. Pre-exposure, we can give the vaccination, that is a live attenuated vaccine. That's contraindication for pregnant women and immunosuppression patients. There are 2 doses, subcutaneous 2 doses we can give after 13 years. We can give after age 1 to 12 1 dose, and after 13 years 2 doses. And post-exposure, for the that's also depend how is the contact activity. If it is less than 3 days, there is a effectiveness around 80%. If it is more than 5 days, the effectiveness is low. Then we can give the antiviral drugs, isolation, and we can tell all the hygiene and everything. And we have to inform our MOH also. Any problems? Any question?
Doctor, excuse me.
Yeah.
Yeah. What is the correct timing of starting acyclovir? Is it first 24 hours or
For what?
starting
As a
delay have
prophylaxis?
as a treatment?
As a treatment. As soon as you get the blister, you can start. That is if more effective when you're starting, but earlier than whatever the earlier.
Thank you.
Welcome. Do you having any questions? Acknowledgement, College of General Practitioners of Sri Lanka and members of Spice Route Sri Lanka, my mentor, Dr. Bihan, and Dr. Sank and Dr. Gobit, who helped me a lot to do this presentation today. And my college, my colleagues of MCGP 9th batch, and my husband and sons. Reference Oxford Handbook of GP, Dermatology Handbook, CDC Guideline, and Sri Lanka Medical Association Vaccination Handbook, and Chickenpox Fact Sheet from Epidunit. Thank you very much. Do you having any problem? Any question to ask?
Can I just add that the crusts are infective? Although you say when you are crusted, the patient is not infective. Once you start the baths, when the crust start falling off, only the infection of others come up.
When the crust are forming, their infectivity go down. If it is infectivity, it's in the blister form, the secretions are there. The crust formation means it's dry, no? There's no chance of getting infectivity.
Dear Dr. Supipi,
Yeah.
I would like to relate your topic to your presentation. Reflection, you mean. As a GP, you have done your evaluation with your first contact, then re-evaluated and thought back and got down your proper diagnosis with the reflections. I suppose the main theme in this presentation, I mean, you should learn from your experience and the findings you get with your practice, and to think back and learn more things by your experience. Your title would be, I suppose, to give this message to every GP. There should be some thought backs to get the proper things learned. We are eternal learners. So CPD session is also a learning point. So the GPs who have joined as well as the specialist, especially the madam who joined now, has said we have to learn from our experience and gather some things from your reflections. Thank you very much.
So Pranit, if there are no questions in the chat box, shall we wind up giving Supipi the certificate for the webinar she conducted?
I'm sorry, something wrong with my connection.
It's okay, Supipi. I have shared the certificate with you.
Yeah.
Yeah, it contains CPD points. You can have it with you when something there is any need. There is some CPD points with the certificate. You can use it.
Thank you very much.
Thank you for your kind presentation, as well as we have learned many things from your presentation and new things we have gained. Thank you very
Thank
much.
you very
So
much.
we'll be winding up this session.
Thank you very much. Thank you very much for all.
Okay,
Good night.
bye.
Good night.
Good night. Good night, all.
All.